Now?
We can see your full PowerPoint, so your notes in the, which will work too. But
how about that?
No, there you go. Perfect.
Oh, perfect. I have two screens, so I think that sometimes get tricky when you present. Okay, so today I'll be talking about art project that we did a long time ago. I realized was done almost 20 years ago. So yeah, that was an intervention that we did at the hospital in Madrid. And the intervention was done in 2007, 2008. So I'm going to give you a little bit of background, and I came across this nice exercise on childhood cancer historical review that was published in 2022, and basically talk about like the main milestone that happened in pediatric cancer and exercise. And it was funny to find that article that I will talk today here in 2010. So if we take a look over the history of pediatric cancer and exercise, we are a relative very like new field of practice, right? I think the first observational studies were happening in 1990 when they started to realize that some of the medication that were administered during pediatric cancer were damaging the heart and the lungs. After that, we started to see a few interventions coming in 2004. First, we have one that talked about the immune system recovery performed by Shore and Shepard, and that was one of my inspiration for the article that I will talk out today. And then we have like with my former group in Spain, we did a pediatric gym in the hospital in 2004, and we have a bunch of different interventions going on there. And as I say, in 2010, I think we had the first intra-hospitalized exercise intervention during hematopoietic stem cell transplant. So really before that article, I don't think we had much done. And I really love exercise as a tool, as a therapeutic tool to help kids to come back from the side effect of treatment. But I always had in my mind that we really need to find out clinical effect that will motivate clinicians and physicians to get kids involved in exercise and physical rehabilitation. So that way we started to think about study the immune system in kids during bone marrow transplant. So the aims of the study that we present were basically assess the safety of doing an exercise intervention during the whole hospitalization period from bone marrow transplant for hematopoietic stem cell transplant. The intervention was about 3 weeks, and we basically stay with the kids, training them during the whole neutropenic phase in an isolated room. And we exercise with them 5 days a week. The idea was to try to do like 3 days aerobic training, 2 days a combination of aerobic training and strength training. And we really were looking into see if exercise could damage the immune system recovery at all. Our hypothesis was no, but we didn't know at that point. And then we also look into body mass and fat-free mass and body mass index, just to see the kids that exercise were able to maintain their body weight better than the kids that were a control group. We didn't have much bone marrow transplant at that time at the hospital, so we decided to do a historical control. Was a blinded selection, so the person who select and dig into the charts was blinded for the exercise group. And we end up having 7 kids in the exercise group and 13 control groups. The mean age of the participant was 8 years old for the exercise groups and 7 years old for the control group. All were cancer patients diagnosed with a cancer disease, most of them acute lymphoblastic leukemia. The regimen, the conditioning regimen was non-myeloablative conditioning. And we did 3 measurements before conditioning regimen started, just a few days before they get into the hospitalization, then in the day 15 after transplant and day 30 after bone marrow transplant. So I was just going to dig into the result. We have really great result. Was a really small sample size, so we have to take those results really carefully because it was just 7 patients in the exercise group. But we observed that the kids that were exercising during bone marrow transplant, they increase their bone mass index and they also the body mass compare with the control groups. And that is such an important result since we have some evidence that says that a body mass index lower than 20 increase the risk of mortality in patients, especially that article was in adult, in patient under bone marrow transplant. And I think the other really thing that we saw in the study was the fact that exercise did not affect the immunological recovery. All the kids in the control group and the exercise group have a median stay in the hospital more or less about the same time. They recover the neutrophil count at the same time, platelet levels, they receive the same amount of transfusions, so there is not any inconvenience to exercise during hospitalization. So I think that was a huge thing because before that, I will say that pretty much exercise was kind of contraindicated. And I think in this article, as I say, it was a very small sample size, so we really need to interpret those results with caution. We realized that exercise was safe. As we say here, we didn't find any difference between control or intervention in any of the leukocyte, lymphocyte, monocyte cells that we assessed. The only one that we find a different was in dendritic cells. And we didn't have like a much explanation about that, and was mainly between the hospitalization start and day 15. What we saw is like the control group drop the dendritic cells much faster than the exercise group. That was the only difference that we were able to find. And of course, limitation, we have tons of limitation in that study. I will say like the small sample size is such a huge limitation. It's not a randomized control trial. We didn't have the amount of population to do that at the moment. We did not use gold standard measurement to assess body mass index. We did kind of basically an indirect measure with skin folds, and we did a calculation using a formula. So we did not assess also the functions of the immune system. We just assessed the number of cells that recover and the time in which they recover. And we also did not assess calorie intake. So we don't really know if the increase in the body mass index was because of the calorie intake was different or because some relationship with the exercise program. So as I say, I think we have tons of limitation. This article was done, as I say, almost 20 years ago. But I think was a good start just to start showing that exercise is possible in this population. And I will say the benefit outweighed all the possible risk that happen in that population. I just want to tell you just a quick thing about more like anecdotically. I remember the nurses kind of at the beginning when we started the intervention, they were really kind of cautious and they didn't know what we were doing with the kids. I remember the parent the first time that they left the room because just one person was allowed to be in the same room at the time with the kid. They were in the window just looking and say, what are you doing with my kid? But it was so nice to see that after 3-4 days, the parents just came to me and say, okay, so you stay like for about an hour? Bye, I'm going for a coffee. So that was such a cool thing to see. And I remember the nurses saying like, I don't really care what you're measuring about the immune system, but the kids are so much happy and they have like so much energy. So I think those are really amazing things that we did not measure, unfortunately, but were like really subjective measure of the work that we all do. So yeah, I will round up because I'm running out of time. So as a clinical recommendation, I will say always individualize exercise program. Not every day will look the same. Really try to encourage the kids to listen to their bodies. They're no better than anyone, what they are able or not to do. Give them choices, so that help them to feel in control. Create rapport and make it fun. I think that is a huge thing. If you really have the ability to connect with those kids in a stage in which they're very tired, they're fatigued, they don't want to move, I think that's make a huge difference. And then try to balance your research objective and try to utilize the resources that you have already in the hospital to do not overwhelm families. And I'm gonna take those ones for the next. So I'll stop here. Thanks so much for listening. And I think I'm gonna pass it to Anne.
Okay, thank you, Caroline. That was a perfect, I think, lead in, and I echo so many sentiments you shared, especially on that summary slide. Let's see, share. Ooh. Let's see. There we are. Oh, something doesn't want to help me. Here we go. Can everyone see then that first slide? Okay. So what I'm here presenting is a little bit different as far as when we look at research studies and everything. We actually initiated a standard of care through a quality improvement project. So that is what I'll share. Transplant Energize Me Patient Outcome, also known as TEMPO, was a quality improvement project to look at maintaining functional mobility in pediatric patients admitted for allogeneic hematopoietic stem cell transplant. So just to go for a quick summary of what is TEMPO, what does this look like? We, prior to establishing this QI project, we didn't have regular intervention of physical therapy, occupational therapy on our bone marrow transplant unit. Actually, frequencies were low, consults were more inconsistent, and the director at the time, Dr. Jeff Aletta, had contacted me and said, I think these kids need more therapy. And I said, I agree. And we started at that moment, and it kind of grew and built from there. So what we established as a new standard of care was TEMPO with the quality improvement side of it, using key driver diagrams and all that fun QI background. We have a very strong clinical therapy department. So we looked at the multidisciplinary approach, not just physical therapy approach, but incorporating PT, occupational therapy, speech therapy, therapeutic recreation, and massage therapy, as well as psychosocial services that we have here at Nationwide Children's. So that was child life, music therapy, art therapy, psychology, chaplain, and I may be forgetting something, but a large number of people. And really what we sought to do and worked hard to do in setting this up was establishing a culture of functional mobility and physical activity. And how do we do that? A lot of communication and working together with the medical team, the nursing team, the therapy teams to get the buy-in and to kind of explain what we were doing, why we were changing, and how we could all work together to help each other. And then also, obviously, that work with the patients and families too. So the aims for our TEMPO QI initiative was first to look at maintaining physical mobility and strength and endurance throughout the transplant period for kids going through transplant. And then second, to evaluate that resource utilization as compared to pre-TEMPO. So for our methods, it is a QI project. So we did have a historical control for the pre-TEMPO group, we'll call it, as well as then looking at that data we gathered from the inception of TEMPO in September of 2016. We took a look at data then through November of 2018 in order to publish in 2019. We had an okay sample size, but low as far as larger studies. So pre-TEMPO, we looked at 89 patients, and for TEMPO, we had 41 patients during that time period. Novel patients. So median age of transplant pre-TEMPO was about 7 years, for TEMPO 10 years, and diagnoses ranged across the spectrum truly. So leukemia, lymphoma, solid cancers, bone marrow failure, and then also non-malignant disorders. Conditioning regimens they could be kind of anyone that kids were having. So you've got the reduced intensity conditioning, the myoablative conditioning, and even the inclusion for some of the total body irradiation conditioning as part of those regimens. Time points of data for physical therapy. We completed assessments at admission, weekly kind of mini assessment check-ins at discharge, and also at day 100. So really kind of going to the results, what we found is that first and foremost, multidisciplinary intervention is safe for these kids during the transplant period. As Carolina alluded, there's been a lot of questions. Is exercise safe? Is it a contraindication? In fact, no, it is safe. I think as everyone would likely agree with this group. And really, how do we then work with the medical teams to get that buy-in also and that trust so we can help these kids to the best of our ability so they can be at their best. We also found for functional mobility, strength, and endurance, we can help maintain it. And I'll explain that a little bit on the next slide, kind of what that looks like. And then secondly, looking at there was no significant decrease in resource utilization or increase. So we'll put it that way. We added a lot of therapy stuff. So if you're looking at this on average, you had 30-minute sessions for at least 4 therapies plus ancillary services. You had a lot more people in the room. So the nosocomial infections was a number of infections was a big thing we wanted to look at, and there was no big change. Length of stay, again, we just see some general stuff looking at total parenteral nutrition, that PCA use or pain pump use. The exciting part for that piece for resource utilization, we saw a good trend, but we weren't able to establish significance at the point of initial data analysis. So we're hoping perhaps as we look back later with larger sample sizes and some more regimens in place, and we'd be able to look at that a little more carefully. And then also those readmissions. But looking as far as more the physical therapy metrics and what are we doing? So these are 4 of the highlighted metrics that we used. I will say with tempo, the physical therapists were completing the functional mobility score, which is a novel measure that I hope to develop for tempo. And we will soon have out more. We just completed a reliability study. So more to come for that. But really just looking at general mobility within the BMT atmosphere, these kids, because of neutropenia and other factors, are limited to their rooms for much of their admission. We needed something to help kind of objectively quantify how are they doing. So this is looking, so what the FMS includes is supine to sit, sit to stand, walking at least 10 feet, up and down a step 3 times. At the time of this data, that was those 4 elements, we expanded to get some better sensitivity. So we now currently also include floor to stand and also reaching to the floor to pick something up, really trying to mimic those functional tasks that kids would need to be successful at home. There's FMS. We use the 6-minute walk for endurance, the 5 times sit to stand for some of that quick burst strength, and then our OT colleagues complete grip strength for us. One thing to pause with the results, we did not have it for this manuscript, but each of the therapies, occupational therapy, physical therapy, therapeutic recreation, and massage therapy all created novel outcome measures for this to then really help not only within the physical therapy domain, but then everyone in with their respective colleagues to help advance within this group of kids. So back to the graphs. The exciting part, what we saw, you can see what we would typically expect, right? We come in with a baseline, and I will say the baseline is when they get admitted to the hospital. So that is a limiting factor we can chat about. It's not pre-BMT admission. It's kind of at that time of admission. We don't have access to the kids often prior to. What you can see is the same trend for the FMS, the 6-minute walk, grip strength, and 5 times sit to stand, although sit to stand's opposite just because increased time is decreased strength. What we saw is they came in at a level, they had their drop during that mid-transplant point, which we were measuring weekly. So we defined peak as the lowest value they had. At time of discharge, they returned very close, if not to where they were pre-transplant or at admission. And then at that day 100, they showed continued improvement. And you can see then the p-values are listed in the article, and I can answer questions for those that are demarked there with the asterisks. Again, just to keep this as a quick summary. So limitations, this was a QI project, not a clinical trial. So you look at the rigor of data collection, that is something that we could work in future studies in future time. We had a small number of patients, so that did affect our statistical analysis as far as being able to stratify the data analysis to look further at certain components. We don't have a comparison group or a pre-tempo group for the functional mobility, strength, and endurance, solely because prior to tempo, we didn't have an established standard of care for PT for this group of patients. One other limitation and something that we worked on these last two, we have kind of made some strides, but still a lot of things to come. We didn't have a protocol for physical activity and exercises specific. So we provide individualized treatment plans for the kids because they could range, as you could see, from 1 month essentially all the way up to 23, 25 years old. So really looking at developmentally appropriate activity, developmental activity engagement, really trying to focus on endurance and strength, but also modulating it for what they were able to do at the time. But we don't have that strict protocol, that good fit model that's coming out in a lot of things now. So then you can have good replication. And then lastly, quality of life metrics. Unfortunately, we had a plan to have these involved in at time of data collection. Some things came up, so we weren't able to publish on those, but we have since incorporated the PROMISE mobility as a PRO into all of our tempo assessments too. So kind of just clinical implications that pediatric patients undergoing hematopoietic cell transplant can benefit from regularly skilled therapy intervention with multifold results. And again, I'd echo all of the recommendations too from Carolina as far as the importance of family and patient-centered care, getting the rapport and just the communication across the team, because we found fantastic results with our nursing colleagues and other colleagues on the floor that realized we could all work together to help the kids to be at their best. Thank you. And I will pass the baton.
Okay, I'm going on. Can you see my presentation? Hi everyone. I would like to present our article named Effects of Multimodal Exercise on Clinical Status and Patient-Reported Outcomes in Children Undergoing Hematopoietic Stem Cell Transplantation. There is little information when we start this project regarding effects of exercise interventions in pediatric population of undergoing transplantation, since they have problems in many different aspects. We plan to study use multimodal exercise interventions, and we aim to investigate effects of multimodal exercise program on clinical status and patient-reported outcomes, including pain, fatigue, depression, and quality of life level of the children, and also for we'll look at also parents' quality of life level. Totally 26 children we included in the study. For intervention group, we use a wide model exercise intervention, including strengthening, endurance, stretching, and relaxation exercises. These exercises were performed by the physical therapist during every weekday throughout hospitalization, and at the discharge day, these children received home exercise program, including what the children need according to the physical assessments. For control group, they received recommendations regarding the importance of being physically active during this process, and our outcome measures are daily clinical status of the children, the presence of anemia, thrombocytopenia, neutropenia, and gastrointestinal symptoms we recorded. Also daily fatigue and pain level, children's depression level, and quality of life level of both children and their parents were recorded. Patients were assessed before transplantation at the discharge day and 1 month after from the discharge day. Let's look at the results. The mean age of the children was 9 years in intervention group and 6 years in the control group. The mean exercise sessions for the intervention group was 28, and the participation rate to the planned exercise sessions was 72%. When look at our results, there was only a significant improvement in intervention group in pain level of children during the hospitalization about clinical status of the children, and also children's depression level in intervention group was improved significantly during the process. And also quality of life level of the children and the parents, both in total score and for children, anxiety and communication scores were improved. And also for caregivers, total score and physical abilities sub-scores were also total score was declined in control group, and physical abilities score was improved in the intervention group. We have limitations, of course. No randomization or between the groups. We couldn't do this, and small sample size is also our limitations. Also, we didn't get any record from the physical activity level of control group during the process. Maybe they are active, they were active, but or maybe inactive. We don't have any information about it. And also compliance to the home exercise program after discharge to the intervention group was very low. We gave them some diaries, exercise diaries, but they didn't feel it, and parents usually say that we couldn't do the exercises. Our clinical recommendations, individual, of course, and if possible, supervised exercise interventions are much effective. They really don't want to do exercises individually at home. And we should also take into consideration individual needs of children. Their daily clinical status is changeable, so we take into consideration, and for clinic exercises and children's preferences also is important. Exercise program is not linear. It may vary from day to day, so we need to consider exercise program day to day. We need to decide we need to some differences about the program, and also we should consider different exercise options to increase children's participation to the program. There is still more evidence needed regarding effectiveness of exercise on physiological parameters or recovery after transplantation, especially long period exercise studies is needed, I think, before transplantation, to maybe 3 or 6 months after that. Also during an inpatient period, children need motivation and supervision. After discharge, maybe facilitators, barriers of exercise can be measured, and patient family education, engage family to the therapy, and close the follow-up of this group is important, I think. Thank you.
Rani, you're muted. Sorry, I couldn't see the microphone, sorry. So I'm going to present you our paper that is Rehabilitation in Children and Adolescents Undergoing Stem Cell Transplantation, a pilot study focused on motor performance. Well, we already know that previous treatment, severity of conditioning regimen, length of isolation and hospitalization can impact physical, cognitive and psychosocial functions, reducing autonomy and quality of life. Different kind of interventions had a positive impact. This is what we can read in the available literature, but we don't know which one of these intervention is more effective. So we can just conclude that it is important to avoid inactivity. When we performed the design of these studies, it was 2016, and we had made in these years a review of the literature about this topic. And so we have seen that most literature that compare two kind of groups propose exercise interventions versus non-exercise programs, or versus usual care or mental relaxation training, without calculating for the type and intensity of activity performed by the control group. So we started from this consideration to build our design of the study. The primary aim of our study was to evaluate the effectiveness of two in-hospital interventions in the maintenance of motor performance in children and adolescents undergoing hematopoietic stem cell transplantation. We also had some secondary outcomes. At first, to evaluate the intervention's feasibility, their impact on fatigue, on maintenance of ankle dorsiflexion range of movement, and on muscle strength. So we design our study as a non-randomized controlled pilot study. The sample presented in this paper is from 5 to 18-year-old subjects, but we enrolled in the study also another population of younger children, but we didn't include this population in this paper. The sample was made up of subjects with oncological or non-oncological diseases during hospitalization for autologous or allogenic hematopoietic stem cell transplantation. The primary outcome was motor performance, and we decided to use as outcome measure the gross motor function measure, acute lymphoblastic leukemia version, because this is a very practical instrument that allow therapists to investigate a lot of physical performance, and so we found that this is really useful to build the subsequent treatment. Well, we had two groups. The first, the control group, that followed rehabilitation counseling indications that were explained to the patient, to the family, and that was also given through a pamphlet in which families and children, adolescents can find some suggestion on how to promote their bed mobility or out of bed mobility with different kinds of activities, and the suggestion was to follow this indication for 7 days a week. We also checked the adherence to this kind of suggestions, checking these 3 times a week. Then the exercise group performed the exercise program with the following of rehabilitation counseling indications. In particular, the exercise program was made up of 3 different kinds of exercises: training, aerobic, and stretching exercises that were performed for 30 minutes and for 5 times a week, with the supervision of a therapist for 3 times a week. Well, the results was that we enrolled 39 participants, but at the end we only had completed data from 30 subjects in the exercise group and for 13 subjects in the control group. The surprising thing was that already at baseline, 68.8% of participants already presented low motor performance, and you have to take into account that we established that subjects who were already undergoing rehabilitation couldn't be enrolled in the study. So this was all patients that we perhaps would never meet, or that we hadn't met in that period before the evaluation. So we performed the evaluation at the entrance in the stem cell unit and at the end of the hospitalization. And considering the 2 groups, we didn't found any significant statistical differences. So we considered the overall performance, and we saw that motor performance were the same at the entrance and at the exit of the stem cell unit for both groups. The fatigue levels decreased during the hospitalization from the entrance up to the end of the hospitalization, and also that ankle dorsiflexion range of movement maintain the same degree during the hospitalization. But we had not this good effect on muscular strength. Referring to the adherence to rehabilitation counseling indication and to exercise program, we found that the overall sample showed a statistical significant reduction in rehabilitation counseling adherence between the week -1 and +1. And we also found that there was the same significant statistical reduction in the adherence of children that were in the exercise program, referring to the exercise program itself between the week -1 and the week +2. So the rehabilitation counseling indication were followed in both groups, but there were a major adherence in the control group. And referring to the exercise program, the most performing activities were strengthening and stretching exercises, while there was a minor adherence to aerobic exercises. So the study had some limitations. At first, that the rehabilitation assessment and treatment were not blinded. Then the enrolled subjects were affected by both oncological and non-oncological diseases, as well as they underwent different kinds of transplant, and we didn't have a sample so big to perform different analyses on these subgroups, and most of all, the absence of randomization. Talking about the clinical recommendations that I can share with you with my experience in this field, I think that it is really important to adapt rehabilitation proposals to subjects' own preference, to adapt play to become exercise in younger children, and to remember that to do a little bit is better than doing nothing. And another important key point from my point of view is that sustained functional mobility should be a goal, not just of a physiotherapist, not just of an exercise physiologist, but of the entire multidisciplinary team. and then I will share after the last slide with my key points. Thank you.
Thank you. Those were all great presentations. Does anyone have a question that they'd like to ask one of the speakers? I can start off because I do have a question. So Carolina, you mentioned that participants, the nurses and the parents noticed that the kids were happier and had more energy with the intervention, but that you didn't assess it in this study. Are there assessments that you would recommend for another study or clinically?
That's a great question, Lynn. And as I say, at the time that we created the study, we really didn't have much resources. So basically all the assessment that we did for the immune system were like already done as a practical standard care in the study. So we did not have any quality of life assessment, or we didn't assess fatigue. So I definitely will love to assess for sure like quality of life or fatigue levels during the hospitalization after an exercise program.
Thank you.
You're welcome.
Anyone else?
I think Prince has their hands up.
Okay, Prince.
Yeah. Hi, everyone. Thank you so much to all the presenters for the very wonderful presentations. I think I've learned so much as well. Being in a setting that we don't do bone marrow transplant, it's actually amazing that it's actually feasible and safe to implement the exercise interventions. And we look forward to brighter days when we shall have bone marrow transplant in our setting. My question, I think it might go specifically to Vesile and possibly Francie. In your presentations, you mentioned of a concept of adherence, how you were able to measure the adherence of the exercises at home. I think this is an area that I also personally struggle with, and I'm hoping to learn how were you measuring adherence and also ensuring that the patients as well as their guardians were able to follow through the exact program that you wanted them to implement at home. Thank you.
I can start. We only record the hospital exercise sessions participation rate. So it was easier, but for home program, it is very difficult, I think. In terms of children's parents are very much responsibilities about children nutrition, other things, clinical status, their medicines they have to take. So we gave them a diary and we ask we told them to every day you should yes or no you write here for your exercises, but maybe 2 or 3 caregivers were returned to us. So I think it is difficult, maybe for future studies, mobile devices, or more follow-up with telephone calls or another things may be more effective, I think.
We did not propose the exercise program at home because we performed our intervention during hospitalization, but for children that at the end of hospitalization showed some signs that let us understand that they need to perform a rehabilitation. We continue the rehabilitation program inside to the hospital because they used to come to the hospital for medical control at the beginning 3 times a week and then 2 times a week. So we perform rehabilitation program inside the hospital, but referring to the unsupervised exercise adhesion, we found that it was really useful to involve nurses, doctors, other professionals in asking parents and children, adolescents, if they performed the exercise for that day, because we didn't give them the possibility to have supervision all the days, because it was not possible for our resources, but we gave them a diary, and so we checked the diary, and it was something that we made with other professionals. I think that to let the family feel that we are a team and that everybody thinks that this is important is something that is really motivating to increase the adherence to rehabilitation exercise proposals.
Wow, excellent. Thank you so much. And just a bit of an extension, sorry, mindful of the time as well, but did you have any visual aids that you were giving out to the patients? I'm just also thinking on my head, right off the top of my head, if at all, maybe such could be implemented across, like if you have any visual aids that maybe you were handing them to the patients to help them at least remember the exact exercise.
Did anyone give handouts or to the patients so they knew what exercises were prescribed?
I can speak to that one. We do. So we kind of use some different multimodal education, because you're right, it's so key for one, the carryover, and then two, also the parents and the kids have a lot of people coming in. So to remember what's going on during the day, we often will print copies of a home program through MedBridge is a program we use. And we would copy that. We kind of ask the kids what they wanted, like what their best form of learning was. Some kids we'd draw like funny pictures, other times we'd go through it, but we'd print that out. And that system also has an option for an app where you can scan the QR code and it'll show the families videos of the exercises you're recommending. So we've tried to lean on that a little bit more inpatient. Typically we did it at time of discharge or follow-up, during clinic visits, but we have tried to integrate that more into the transplant period for good compliance with recommendations for home program.
We have quite the same in Italy, because as members of the rehabilitation working group of the Italian Association of Pediatric Hematology and Oncology, we have a website where physiotherapists can charge some different videos, and we can prepare some indications for parents with the QR code, so they can see the video of the exercise. It is a very nice thing, because we have a lot of videos made up by a lot of persons, so it is nice to see, okay, tomorrow you will do some exercise with my colleague Marco that works in Milan. It is something that is nice, and I think it can help for unsupervised exercise.
Well, thank you.
Wow, thank you so much, guys. Thank you.
Prince, I also want to say that we did not use any of that in our trial, but we did another intervention in which we use also kind of video game stuff. We use the Wii to help the kids to move. So we have like Wii dance, Wii Fit in the room with the kids, and that helped them to stay much active for sure.
Wow, I love the creativity. Thanks for sharing.
So I know we come to the end, so please know that we'll understand if you need to leave. I think there is another question here from Pia. To all speakers, there were different scales and tools that were used for the assessment of the intervention. Nowadays, which one do you think is better in BMT? If you were to choose one today. This is always a hard question.
That's a very tricky question, Pia. I think it's so hard to find the same type of assessment that will work for all the different environments. But I will say, like, from a practical point of view, I will say that it would be nice to have certain type of assessment that doesn't require much space, and you can get those done inside the room. So then you can be sure that you can repeat through the whole transplantation process. For sure, if you have like some standards, standardization, and you're able to go to any of the gold standard measure, that would be great. But I think it's quite difficult when you are just limited to a room. So I will pass it to the rest of the team to see if they have any other suggestions about assessment.
I will say, I think one of the challenges too that we found and why we developed the FMS in part was we weren't finding that one assessment that we could do quick and easy to get a good objective picture of the status and what could bridge across age groups. So we weren't doing 5 different measures from birth, on. Typically, I'll say the FMS, we're using 3 and older. And typically for 42 months and younger, depending where the child is developmentally, we'll use the Bailey. It was a Bailey 3 when we started, it's a Bailey 4 now. And we're kind of doing some correlations just to have a measure for the young kids, because we really do get a lot of young kids. But for the older, I think that's where we've leaned into the FMS. We get that standardized, the 5 times sit to stand, some of those easy in the room. All of our rooms have a mat and a foot bike as well. So that allows some, and then we just bring in a step stool. So trying to keep it simple.
I love assessment tools that give the possibility to understand on what we have to work. So I really like functional outcome measure, because they give me suggestions of what to propose to the child. I know in deeply gross motor function measure, because in Italy it is really used in pediatric fields. So I found that it is practical, but I think that we will need to achieve a consensus on which kind of assessment tool we can use, taking into account the things that Carolina listed, because we need something that is cheap, that is quick, that is that it can be performed in very different situations, settings. So perhaps we can think about the possibility to work on this point in the future.
Yes, I agree with the other speakers. There is small rooms. We need to be quick and use the things we need to use. So in my practice, I use 5 times to stand, sit-up test, 12 seconds, or some measurements about stairs, go and down, and that's it. And also, of course, take pain assessments, patient-reported some outcomes can be useful. Thanks.
All right. Well, thank you everyone for your great questions and speakers. It's so nice to put all the articles together and learn from, people that are doing similar but different things at each site. So I really appreciate all the knowledge that you shared today. And so for everyone that's here, make sure you continue to look out for our announcements. We plan to do at least one educational opportunity every quarter. And then we also have business meetings for our SIG. So with that, anything to add, Abu or Pia? Okay, well, everyone have a nice day. Thank you all again.
Thanks so much, everyone, for your time.
Thank you.
Thank you, everybody. See you. Thank you.
Thank you. Great job.
Thank you very much.
Bye.
Thanks, everyone. Thanks to our speakers.
Nice to see you.
Bye.
Bye-bye.
Bye.